Okay, so we will start. Good evening, everyone. Respected Dr. Yuvaraj sir, member of the Safe Dental Updates, and dear doctors, we welcome you all for our 14th Learn from our Master Series organized by Safe Dental Updates, and it's a great honor to be here. So firstly, we would like to introduce ourselves. We are Safe Dental Updates, a dental platform in which we believe quality education always ensures predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professionals and guide your dental journey. So without further ado, let us start our series in which our topic of discussion is Regenerative Periodontics, given by Dr. Yuvaraj Marudhappan sir. To speak a few words about him, he completed his BDS from GDC Chennai and MDS in Periodontics and Implantology from Dr. MGR University. He runs an exclusive implant and laser practice at Namakkal, Tamil Nadu. He is also a consultant periodontist and implantology for many clinics in Kerala and Tamil Nadu. He is a renowned speaker who has delivered many lectures and successfully conducted workshops of Perio Skill Enhancement Program in Kerala and Tamil Nadu. So without wasting more time, I would like to invite Dr. Yuvaraj sir for today's discussion. Sir, please.
Thank you, Shanu, for that introduction. As usual, you are very generous and you had very kind words about me. I think I am audible, right?
Yes,
Shanu?
yes, sir. You're audible, and even the visuals are fine.
Visuals are fine. Fine. Okay. If anything happens, you just let me know, or you can let Harish also know. He'll intimate.
Sure, sir.
Anything
No
happens.
problem.
Okay. Thank you. So let's see why we are here. So, as Shanu asked me about the topic for today's webinar, I had many topics in my mind, and then I suddenly thought about this regenerative periodontology. One, because in most of the clinics, wherever I go for consultation, they ask me this general question. The clinicians, wherever I go for consultation, or even participants who come for our programs, they ask me this general question: when to graft? Where should I put the grafts? Or when we are elevating the flap, should I put grafts somewhere here, sir? So these are general queries which the participants and the clinicians ask, and I think that there is a general misconception about the usage of bone grafts. So I thought that this webinar should be useful from clinical point of view and should enlighten and show some vision on cases where we can use bone grafts, because like bone grafts comes at a cost, and we should not put it where it's not required. So I'll try to enlighten from a clinical point of view. Now, regenerative periodontology itself is a big volume. As you all know, it's half of Karanza is based on regenerative periodontics. So I'm not sure that I'll be able to address an entire conceptual regenerative periodontology to you. But we'll limit ourselves to clinical point of view. If you get a case in your clinic, and if you're seeing an OPG, or if you're seeing a case clinically, whether to graft, whether to attempt a regenerative procedure or not. So we'll limit ourselves to that, and we'll see. I'll try to maximum simplify this topic for you. Let's see how it happens. So, as I said, periodontal regeneration or regenerative periodontology is concerned with both soft tissue engineering as well as hard tissue, or the bone fill which we are expecting clinically. Now, these two are entirely different, and these two are vast. So, we'll limit ourselves to bone grafting and GTR techniques, or in simple words, from clinician's point of view, a bone fill. Previously, radiolucent area in an X-ray, how to get a radio opaque area in that X-ray, and how to form bone in that region. So that's what we'll be seeing in this particular webinar. We'll be not dealing with the soft tissue enhancement or soft tissue engineering, or any kind of connective tissue grafts, not like that. So let's see about the regenerative periodontology from the clinician's point of view. Now, in order to understand regenerative periodontology, this is the basic. This slide is the basic. Now you should understand the difference between these three types of defects here. So one is a suprabony defect, the other one here is a infrabony or vertical defect, and there is a furcation involvement. Now these three are commonly found defects or commonly found bone loss patterns in a periodontal case. There are some other defects also like craters and ledges. There are wide variety of defects. We will not deal with that. All of them will come under a horizontal defect or a suprabony defect. Now, an infrabony or angular defect or vertical bone loss and a furcation defect. Now, these two are a most favorable sites for regeneration, I would say. If you see a defect like this, you can attempt to put graft over here. A site like this, no point in placing the graft. The patient goes home, he rinses, all the graft material will come off. So in order to understand this regenerative periodontology better, you understand that there should be a place sufficient enough to hold the graft material, whatever you're putting. If there is no such place, there is no point in placing graft there. It will be a total waste of time and money. So hope you understand the types of defects. We'll see cases for each type of defect, then you'll have a better understanding. And when I say an angular or an infrabony or vertical defect, it can be again of these three types. It can be of these three types where you can find a defect completely surrounded by bone. Sometimes you have only two walls. So this is a three-wall defect, a defect surrounded by three walls. And this is seldom visible on an X-ray. If you take an X-ray, it will appear completely normal. But when you probe that region, the probe will enter and it show almost an 8 to 9 millimeters of defect here. So since it has got bone on all the sides, this defect goes missing in an X-ray, and clinically it can be verified by checking the probing depth around that. And we have two wall defects. So the name or terminology comes from the number of walls remaining. Now here you can see only two walls are remaining, that is a lingual and a proximal wall remaining. The buccal wall is completely gone. So this has got a slightly less chance of regeneration. And then we have one wall defect. So this is most commonly seen in posteriors. These two types of defects are seen in premolars and anteriors. So this type of defect is commonly seen in posteriors and has got a very less chance of regeneration, I would say. But from a periodontist point of view, I feel that all these three defects has got the same chance of regeneration. All these three will come under an infrabony or vertical defect, and all these three has got a similar chance of bone fill or regeneration if the conditions are good, if the other factors like periodontal infection, systemic factors, endodontic factors, and tooth mobility are under control. Now, these are important factors. There are many other factors also like age and other systemic factors. I'm not going into detail of that. From a clinical point of view, these factors are important, and among that, the most important factor is the endodontic factor. We'll discuss about it. We'll see the cases regarding that, then you'll understand better. And tooth mobility. Now, this is something which has to be strictly followed. There's no point in grafting a tooth and just keeping it mobile. A tooth should be stable. If you're going to put graft around it, only then there will be a chance of regeneration. No point in grafting and having grade 2 or grade 3 mobility around that tooth. Doesn't work like that. And periodontal infection systemic factors, we'll see. Now, for example, take a case like this. A patient comes to your clinic with a complaint of foot impaction and periodontitis. You check, you find there is some kind of bone loss. You advise for an OPG. Patient comes back with an OPG like this. Now you can see the white line over here shows the remaining level of alveolar bone. So with this, you can come to a conclusion whether it's an advanced or a moderate or a mild periodontitis case. Now in this clinical scenario, if you take the second quadrant, you can find that there is a horizontal bone loss. You can see this flat line, right? So this shows that there is a horizontal bone loss, but in relation to these two premolars, you can see a slight angular bone loss, right? And then again, it becomes a horizontal bone loss till the first quadrant. So the entire upper quadrant, you can see a horizontal bone loss from X-ray, and only in relation to these premolars, you can see a vertical bone loss. So if you are going to put graft somewhere in the upper arch, it will be in this premolar region. No point in placing graft in this horizontal bone loss region. The graft will never stay. There is no chance of regeneration in that region. Right? And similarly in lower arch, if you see, so there is a generalized horizontal bone loss pattern, but when it comes to these two molars interdental aspect, you can see a vertical bone loss, a nice angular bone loss. Now, what is the type of bone loss? That is, it is a 3-wall, 2-wall, or 1-wall. We can never make from an X-ray. Always, when we open clinically, only then you can visualize it. So, from this X-ray, you are ready to do a flap surgery and ready to place graft into that defects. But let's see the clinical aspect. When you take the clinical aspect, you can see this inflamed gingiva. The patient is diabetic. The soft tissue, the gingival condition is like soft, edematous, friable. So there is no chance, no way that if you're going to put the graft there, it will be free of contamination. So this much of inflammation, you can never attempt a grafting procedure. So even though the X-ray is suggestive of a vertical or angular bone loss, you cannot undergo a regenerative procedure in this case because of the consistency of the soft tissue, because of the systemic influence. So this patient has to go for control of diabetes first, then followed by a good oral prophylaxis and oral therapy, the phase 1 therapy, then antibiotics, and then when the consistency of soft tissue is good, then you attempt a grafting procedure. You see multiple discharging sinus polyps, the graft is never going to work in this case. So just remember periodontal and systemic factors to be taken into consideration, not the X-ray factors alone. Now, the second and the most important factor, I told you, right? Endodontic factors. Now, endodontic factors are most commonly associated with regenerative therapy, I would say, in an endoperio lesion. Most of the times it's endoperio cases. Whatever grafting or whatever regeneration I'm attempting, 80% of cases will be a perio-endo case. Now, for example, take this case. The upper arch seems to be normal. The patient is just 36, 37 years old. Upper arch seems normal. There is a horizontal bone loss or mild periodontitis in relation to the upper arch, the molars. And in the lower arch, you can see the anterior still premolar. It's fine. But when it comes to this molars, you can find an angular vertical bone loss extending almost till the apex in relation to 3-7, and an angular bone loss extending till the apical third in relation to 4-6. Now, this case, you will find that the patient has discharging pus discharge. Often the tissue got always the tissue got soft, and the patient has the complaint of this swelling every 3 months once or 4 months once. She was often getting the scaling done, and she never took an X-ray, and she was never advised for a periodontal therapy at an earlier stage. And when she reported to us, it was already advised for extraction by many dentists. She doesn't want to get it extracted, and she visited me, and I told her that so and so is the case. You have to go for a periodontal therapy, but before that, you should go for an endodontic therapy. Why endodontic therapy is important in this case? Because you can do a good grafting, a good flap therapy and grafting in these sites. But if the tooth is going to get involved endodontically after your periodontal therapy, then your entire procedure is going to be waste. So the infection from this tooth, the endodontic infection, can spoil your entire periodontal therapy, whatever you're doing. So remember, whether it is endoperio or perio-endo, it's always the endotherapy first, followed by perio. I insist this in all my sessions. Do endo first. Don't take a chance that I'll do perio first and then I'll do endo if something happens in the future. It's never gonna work. So always endo first, always clean the house from inside, then take care of the perimeter outside. So that is how it should work. Why there is a chance of endo involvement in this case? The lesion has already reached the apex, and here you can see that till the apical third it has gone. There is a high chance of lateral and accessory canals getting involved. So we don't want to take that chance of endodontic infection later. So that's why I did an RCT for this case. So this is the same case. You can see periapical, periodontal infection extending till the apex and also extending to the other side of the, that is the mesial side of the roots. Okay, you can see here. So that's why I tell you, always rely on IOPS, never rely on OPGs for your isolated tooth defects. And a nice flap and grafting was done, and you can see almost a nice bone fill after 1.5 years. So this patient recently reported, and when I took an IOP, I was really surprised with these results. Though we have got good results in the past, this was one of the best results I have got. So that's why I have added this. And also the mobility was considerably reduced. Initially, what was a grade 2, grade 3 mobility has come down, and it is not even mobile now. The tooth is rock solid. The patient is going for crown also in this week. So I think if endo was not done in this case, the the entire periodontal regeneration will be in a question mark. Similarly, on the other side, you can see here an angular bone loss, what I have shown there, has almost now regeneration, the bone fill has been done, and it is like almost reached the middle third of the root surface. So this tooth is also stabilized now. There is no mobility in this tooth also. So endodontic factor is very, very important. I'll show, so this is pre-op and post-op of the same case. You can appreciate a nice bone fill in the 3-7 region and also in 4-6 region. You can see almost the pattern is flat now. What was angular is become flat now. So this much regeneration only you can get. No point in placing graft in the upper molars where there is a horizontal bone loss. The graft will not stay. This region will never regenerate and come back. Now, for example, take another case, a similar case where you can see a nice defect in the distal aspect, almost similar to the previous case what we saw. But this patient was not willing for an RCT, though the treatment plan was explained to the patient. The patient was not willing for RCT. So I did a flap. So when I opened it, you can see a nice defect here, right? Remember, I told you there are 3 types of angular defects, right? So this will come under a one wall defect category. Remember, a one wall defect is more common in the posteriors between the molars. You can see it's almost similar to what we are seeing here. It's a one wall defect here, and I placed graft. So you can see graft material getting filled in the defect nicely. So this is how your grafting procedure should be. So this is an immediate post-op of the case where we have filled the graft material and there is an overfilling. Always overfill the defect. Whatever the defect is, try to do overfilling so that remaining graft material, even if it comes off, whatever stays in the defect, it stays safe. So always overfill the defect and suture. Since RCT was not done, this patient developed pain in 6 months, I think, and this tooth went for extraction. So now you can understand the importance of endodontic factor. If the same case endodontic treatment would have been done, then this would have got a nice prognosis and we could have easily regenerated this defect and the tooth would have been saved. So it's so important. It determines the prognosis of your overall treatment. So always give endodontic consideration. If it is involved in the apical third or reaching the apex, always go for endo treatment before undergoing your periodontal therapy. Now, most people will argue with me whether it's really a periodontal regeneration what we are getting or a simple bone fill. I would say that it's not a periodontal regeneration from a periodontist point of view, and we are getting a simple bone fill in the side. So why I'm saying this? So this is more theoretical, and I don't want to go into technicality of it. Since there is no new cementum formation, there is some radio opacity which is appearing, but we are not sure whether a new cementum is formed. New cementum can never form because we are not applying any agent for that. So there is already existing cementum to which there is an attachment. So a regeneration is not happening, but definitely a bone fill is happening, which is essential for stability of the tooth. So from clinician point of view, it is bone fill. Regeneration. From a periodontist point of view, it's just a bone fill or just a reattachment what is happening there. So need not get into technicality of this. I don't want to go into this. So what are the graphs used for this purpose? Now, this is very interesting question again asked by many clinicians to me, many participants to me. Now, there are wide variety of bone graft materials available in the market. A lot of graft materials. All these graft materials can be classified, can be grouped into one of these categories, either autografts, alloplast, or xenografts. Now, I personally prefer alloplast and xenografts because of easy availability, and also this autographs, allografts are more like technique sensitive, where you have to, where you need sophisticated instruments or what to say, you need refined burrs to harvest the graft, and it's also like traumatic. Now it's more crude also. Sometimes if you do a bone staging, if you try to remove the bone with a burr, it's more crude. So I don't prefer autografts and allografts. I always prefer alloplast and xenograft materials. So any graft material should have these properties. That is, it should have a good particle size. It should not be large. It should not be small. It should be sufficient enough so that we can condense it into the deep into the defect. And it should have a good retention, and it should have a good bone fill properties, and also it should have good osteoconductive properties. So based on all these years of experience, I personally feel that this graft material, osteograft, this I am using for quite a few years now, like 5 to 6 years now. And this graft material is is the most successful one for me in the recent practice, and I'm using it for implant practice also. This is giving me good results. Why it is giving me good results? One, there is a good bone fill, and also, so whenever you do a grafting procedure, so you need an immediate post-op X-ray. So when you take an immediate post-op X-ray, it shows a nice bone fill like this, isn't it? This is nice, right? A good radiopaque fill in the previously radiolucent area. So we can show the patient also that this area we have grafted, and we have grafted to the level of the defect, and rest now stays on how you maintain it post-operatively, and the other systemic factors involved. So in order to show this bone fill, we need some good radiopaque graft material, and osteograft is one of a good radiopaque graft material. You have other graft material also, like hydroxyapatite crystals and tricalcium phosphate, alloplast. So these are not that much radiopaque. Even you put the graft, these are like still the area remains radiolucent, and we are clueless on whether the graft has reached the defect base or not. So we are clueless. So I think this graft material has addressed that issue for me, and it's really easy for use. Once you mix it with saline, it becomes really pliable, and we can easily condense it till the defect. Once you push it, you'll know that it has reached the defect base. With other graft materials, I'm not having that satisfaction, so I'm using this graft. I'm not saying this is the best graft material, but a 0.5 cc of osteograft comes around 2,600 rupees, whereas a same 0.5 cc of Nova bone putty comes around 5,000. So I think this is cost effective also, and user friendly also. So that I'm using it. You also try, and you use other graft material also. Whichever is comfortable for you, you can use it. I am using a membrane along with the graft. So wherever you are putting graft, you need to place membrane also on top of the graft. Why you need to place membrane? To safeguard that graft. So we have again lot of membranes. I'll not go into technicalities or theories of it. There are generation of membranes. Just remember, whatever membrane today we are using, it should have these two basic properties. It should be resorbable, and it should be a collagen membrane. So most of the membranes whatever we are using now are resorbable and collagen. In the market, the resorbable collagen membranes are available. Now, again, there are a lot of membranes available. I personally use this Healy Guide. This is a very good membrane. You can see, so this is a Healy Guide membrane you can see here. So once it is applied into the defect site, it becomes very soft, and it is very easy to work with. It adapts according to the defect. You can easily mold it over the graft material, and it is having a good stability also. Now with other collagen membranes, I find that they usually break. You can apply it, but you cannot manipulate it. With this collagen membrane, the manipulation is quite good, and stability is also quite good. So I personally use this membrane. You can use other membranes also, whichever is comfortable. You can find and use. There is no shopping to it, but I find this as a good one. You can try this. And so this is how you should use a membrane. Sometimes you can adapt the membrane. Sometimes you need to suture the membrane. Sometimes you need to stabilize the membrane, the furcation defect like this. Sometimes you need to suture it around the tooth. So these are different types of membrane adaptation. I'm not going to go detail into it. Just remember, whenever you place graft, you need to place something called as membrane over it in order to stabilize it and in order to protect the graft material. Now, not always these membranes are a good option because of its cost, one thing, and also because the patient might not be affordable. So you can go for a good alternative option, that is PRF. Now, we cannot avoid discussing about PRF when we are speaking about regenerative pedontology. Theoretically, PRF doesn't have that much impact, but nowadays clinically we can see that whenever any kind of grafting is attempted, PRF goes along with this. So what is PRF? PRF is platelet-rich fibrin. The process is very simple. By the time you give anesthesia LA, you ask your lab person, whichever lab person is nearby, you can ask them to come. This is very easily done in your clinic also. Ask the patient to give 10 ml of his blood. You can explain the procedure to him. Then the lab person will take the blood to his lab. He'll centrifuge it like this for 10 minutes at 3000 RPM. And when the centrifugation is done, you will get a test tube like this with three distinctive layers. The middle layer is PRF. The upper layer is plasma. I mean, platelet poor plasma. It will go off. The red blood cells we don't need. We need platelet-rich fibrin. So this is a gel-like consistency, which when you remove it with tweezer, it comes off like a gel. And this PRF you can use along with the graft material like this, and you can prepare a sticky bone. You can see nice graft coated around the PRF. So this sticky bone will have a better retentive property and a better bone fit. Or you can use your PRF, you can squeeze the PRF between two sterile surface, and you can use it as a membrane also. It becomes a membrane also. So instead of your synthetic membranes, you can go for a PRF membrane. Now I'll show you a case, only then you will understand. So for example, take this patient. Remember I told you about three types of defects, right? We have already seen example for a one wall defect, where an OPG showed that there was a complete bone loss and distal to the molar, and we have regenerated. So one wall defect, you all understand. Now I'll tell you something about three wall defect. Now for example, take this case. A bridge was placed in relation to 5 and 6 long back, and this patient had complaint of foot impaction in the interdental aspect of 5 and 6. When radiographically we inspect, there is no bone loss. You can see here that it's almost like fine. There is no bone loss at all. It seems to be fine. But when you see after elevating the flap, when you insert the probe, you can see almost 10 11 millimeters of probe going into the interdental region of 5 and 6. So this is a three wall defect. Confined, the defect is confined between the three walls. That's why it's not showing in the radiograph also. And you can see a nice defect with the probe. The probe goes almost entirely till the apical third, the apex of the premolar. Now I place graft and I use PRF. Now you can see the PRF. This PRF I am using as a membrane over the graft material. This PRF will stabilize the graft as well as it will protect the graft till the bone formation happens. So this is how you substitute a synthetic membrane with a PRF membrane. I know that this will be very difficult for you to understand. Just understand the concepts, just see the cases, and you search in detail about this, you will know everything about this. Don't worry. It's a very simple process getting PRF from the blood. Once you do it for first case, it will be very easy for you. If you have any doubts, you can always contact me. And yes, so this was done. So we have seen examples for two types of defects now, right? We have seen example for one wall defect and also for a three wall defect. So three wall defect often goes missing in an X-ray. So always try to probe that region and find out if the patient is really having some kind of defect. And now we'll see a two wall defect. Now, for example, take this case 1121. Entire bone on the mesial surface is gone in these two teeth, and apically you can see some kind of bone loss over here. You're not sure about it. The probing depth almost reaches like 8-9 millimeters deep. So when I open that flap in that region, I can see a nice defect circumscribing the apex of 1121. Now, this type of defect is a two wall defect. You can see here the tooth is circumscribed nicely on the two walls, but only on the buccal side it is gone. So, this type of defect is a two wall defect. Here also you can do grafting and place membrane. So, you've seen examples of one wall defect, three wall defect, and two wall defect. All these angular defects can be regenerated with a nice RCT and grafting procedure. Now I have done the grafting, but till this region only I can expect a bone fill. Okay, so whatever the 3 or 4 millimeters horizontal bone loss is present, it will not get regenerated. Whatever this periapically circumferential bone loss is present, this will be regenerated. If you take an X-ray after 1.5 2 years, you will find that nice bone fill around these types. So this was done with a consultant, under consultation in some other clinic. So we don't get X-rays that often. So the doctors usually don't keep records. So I don't have X-rays for this, but definitely bone fill will happen. I can see post-operatively some kind of recession, but that is good. You can give a crown till this level, which is actually after the pocket elimination. You can almost see some 7-8 millimeters of pocket here. And after 3-4 millimeters gone, I think the normal circular depth will be established here. So nothing wrong with a bit of recession. Anyway, you are going to give a crown with that. So now we are seeing examples for all these three types of angular defects. Similarly, furcation also you can put graft, and you can go for grade 2 and grade 3 furcations. You can go for bone fill. Now, I told you something about relying on IOPs and not on OPGs for grafting procedure. So this is a classical clinical scenario where you will find that this patient had complaint of uh, buccal sulcus obliteration, I would say, a dull pain and a buccal sulcus obliteration in relation to this 3-6. She goes to a clinic in Chennai. They take an OPG. Now this OPG, you can see some kind of caries here, class 1, involving or not involving pulp, but patient's complaint was not that of pulpal origin. She was more concerned with the buccal sulcus obliteration. And when I took an IOP, she didn't want to undergo treatment then. She came back. When I took an IOP, I found a nice, interesting defect here. You can see almost like furcation, a grade 2 furcation involvement extending till the marginal bone here. So this type of defect often goes missing in the OPGs. There is no clue about that kind of defect here in OPG. So always rely on IOPs for your isolated angular defects, isolated single tooth lesions. So after elevating the flap, you can see a similar type of defect here, whatever was seen in radiograph. You can see here also. So grafting was done, and then suturing, and then you can see a nice keratinized gingiva formed around that. So this is an example of why you should not rely on OPGs for isolated tooth lesions. Always rely on IOPs. Take IOP and check. And sometimes I use grafting for implants also. Now this is a very interesting case what we are seeing here. So I mean a simple case, but still in order to show the bone fill, I'm showing you this case. So this was a root stump involving 6, and I went for extraction of all the root stumps, and the interdental bone was quite good. So I placed an implant in that interdental bone, and you can see these sockets, right? So these sockets will heal automatically, but I don't want to reduce the volume of this bone, this bone thickness I wanted to maintain around the implant. So when it heals, usually the socket they get shrink. Usually you can see in relation to if a 6 goes missing, there will be broad bone around the 6, around the 7 and 5. But in relation to 6, you will see a small constriction in the buccal and lingual cortical bone. So I don't want that to happen. So that's why I place some graft into these sockets. So this is also called as guided bone regeneration. So guided tissue regeneration is something else. This is guided bone regeneration, where you put graft into this extracted socket and help this to maintain the volume. So this volume or width of bone will be maintained. You can see a nice graft filling around the implant. So this is why I tell use osteograft, because it gives a good feeling of condensation till the base. So a lot of my friends have also used this graft material for implant cases, and they find it quite interesting. And yes, you can also try it. So sometimes you need grafting for an intense or big lesions like this also, like a periapical cyst. You remove entire cyst and you can see a big lesion. Put graft into that. You can mix it with PRF also, prepare a sticky bone, put it inside, do some pre-suturing, put the graft and then suture it back. So these are different applications of graft. I don't want to get into details of this again, periapical cyst, everything. So remember the takeaway points. You have to analyze the type of defect first based on the x-rays and also clinically. You can regenerate only angular bone loss, vertical bone loss. You cannot put graft in a horizontal bone loss situation where the bone levels are flat. Don't put bone graft. Rule out any presence of systemic condition and inflammation. These two are very challenging in tissue manipulation. Also, these provide a lot of hindrance to your grafting procedure, as well as the success of grafting depends a lot on the systemic condition information. And the most important factor is the endodontic therapy. If a tooth requires an endodontic therapy, go for it and then attempt a regenerative procedure. A good flap design, again, design your flap, and it should be designed in such a way that the base of the defect is visible to you. Sometimes it's more apical and you're not able to visualize it. That's okay, but go as much deep as possible till at least 2/3 of the defect you can cover. From there, at least you can condense the graft material inside. But if you're not elevating the flap sufficiently, there is a chance that you might not reach the base of the defect. Good pre-suturing and flap approximation. Now, this is very important. As important it is to elevate a flap, similarly, it is as important to close it also without any gaps and a tight contact between the flaps after the graft placement. A good graft and a membrane. Now, this depends on your own conceptualization, I would say. You use different kind of grafts and come to a conclusion which is a good graft material for you. And also use PRF whenever you're using graft material. and post-operative instructions and a good post-operative care. Now, this is the most important aspect of a regenerative therapy, so, which is given the least priority. I would say when you do a good procedure, after doing a good procedure, if the patient doesn't take proper post-operative care, then the entire procedure goes waste. So instruct your patient on what has to be done within 2 hours of the procedure, and what has to be done on the next day morning, what has to be done within 2 to 3 days, and next 1 week. So if you give a post-operative instructions, good post-operative instructions, like simple instruction, don't try to touch the sutures with the tongue, which the patient does often. Don't try to rinse forcefully. Don't try to eat something hard. The patient's most important query will be what to eat. Anything palatable. Don't ask them, don't eat which will take sufficiently high biting force. Anything palatable will be good, like a curd. So these type of simple instructions can even improve the post-operative results. So I would say good post-operative instructions, take some time, take 15 minutes, ask the patient to sit, explain to him clearly on what has been done here and what he shouldn't do. So if it reaches his head, half of your work is done. And good post-operative care from patient's side. So if all these combined together, I think regenerative therapy in perio can prove wonders. But as you say, case selection is very important, followed by the ruling out of other factors and a good procedure. So I think you can do an isolated tooth lesion. You can easily do grafting with some practice on models. You can easily do grafting, and we usually have every month, last Saturday and Sunday, we usually have this Calicut. We usually have this session. We conduct in different parts of Tamil Nadu and Kerala, but this Saturday, Sunday, I mean, October 8th and 9th, I think next week, I'm coming to Calicut. So we can do a nice demonstration, we can do a nice hands-on session on the models also before attempting on the patients. So yeah, so finished, and if you have any doubts, I think you can put it. I can try and address as many doubts as possible. That's
I would request all the viewers to post your questions in the comment section, so which will be rectified.
okay, sure. Yeah, that will be fine. Yeah.
So there's one question. How about amniotic membrane?
Yeah. Yeah. Now, I'm seeing a few questions in front of me. I'll try to address them in an order. Not able to see picture of cases you are telling, sir. Oh, sorry. So I'm really sorry for that. But cases were visible, no, Shanu?
No, yes, sir. Actually, I had messaged them personally, saying that it was actually audible and the visuals were fine as well. Even I had checked by
Oh,
myself and with other colleagues as well.
not no fault from our side, right?
No, no,
Cases
nothing,
were
no,
fine,
nothing,
no?
sir, nothing, sir. I had personally messaged them
Sorry,
also.
actually for Dr. Mili. Okay.
So I think I will read out
Okay.
each questions, and so that
Yeah,
it'll be
yeah,
easy,
sure,
sir.
sure, sir. You can do that.
Okay, so I think there's just one
Yeah.
question which has been posted. It is, what about amniotic membrane? How about amniotic membrane?
Yeah, amniotic membrane. Yeah, as I said, there are a lot of membranes and options available. Amniotic membrane is one of an option. Again, these all comes at a cost. If you buy an amniotic membrane, it will come around 1,500, 2,000. I think you can get it from Tata Institute. Our PGs are using it, but I find PRF to be more useful in these cases. Instead of an amniotic membrane, you can go for PRF. Now there are a lot of studies. If you search for articles, you'll find a lot of studies where PRF and amniotic membrane have been compared. And almost like PRF is also having an equal effect as that of an amniotic membrane. Both of them are having equal effect. Sometimes even PRF is having better effect than amniotic membrane. So I always prefer PRF since it is taken from patient's own blood. It will have a good acceptance. It's freshly prepared. It will have a lot of growth factors when compared to your amniotic membrane, and yeah, freshly prepared from patient's own blood, I think it has always in it. So amniotic membrane is okay, but it is again yet another membrane. It is yet again a synthetic membrane, which cannot be compared with PR. So I personally prefer you go for PR.
Okay, sir. There's another question. I think the answer is kind of obvious. Can we general dentists do this regenerative therapies confidently after attending the workshop?
I think, yeah, most of our participants are doing it, Musha, no? Most of them are posting cases also. I
Yes, sir.
think yeah, you can do. There's nothing difficult about this. You need to do a good flap elevation. You need to have a good graft material. That and all will guide. And you need to know good suturing technique also. So all this, anyhow, our program will be telling. So all they need to do is to get a good graft material, I think. So that is also available in market, and you are also assisting that, right? So I don't think that that should be a problem. Yeah, you can do. Yeah, definitely.
Okay, sir. The next question is, would you speak about post-operative instructions after graft placement? And and what about the follow-up checkups to determine the bone level?
So yeah, post-operative instructions, as I said, you give for 1 week till suture removal. For since 10 days is also fine till suture removal, and then you remove the sutures and then give the instructions to the patients that he should be constantly brushing that region and keeping it clean. There should not be like food impaction happening in that region. In order to get a good bone fill, we need to keep it contamination free. So that is in patient's hand, and you can go for bone check. That is levels you can check with an X-ray after 6 months, after 1 year, and after 1.5 years. For some patients, within 6 months you'll see very good results. For some patients you'll see in 1 year. For some patients you can see after 1.5 years also. So it all depends on the type of defect, as I said. But you can always check bone levels with an X-ray in 6 months. So 6 months you'll find some improvement, though there is not complete bone fill, but definitely there is some.
So
What
this is a
is next
question
question?
from a PG student of Perio. So her question
Okay.
is, does sticky bone plus PRF and bone graft will stay in one walled defect?
Just sticky bone plus PRF and bone graft. Sticky bone plus PRF
Sticky
and bone
bone
graft.
plus
No,
PRF
I
plus
see.
bone graft.
Yeah, so there is no need to put all these things together. Whatever you are asking is fine because from my presentation, I think you have got a concept that all these three are good. All these three are good, but there is no point in keeping all these three together. Sticky bone itself will contain PRF and graft, right? So your graft's retentive property will be improved with sticky bone. Once you place sticky bone, it will stay there. It will have a good retentive property. And when you are using a synthetic membrane around that, it becomes even more stabilized. So there's no need to place a separate PRF, but it will stay. In a one wall defect, definitely it will stay. One wall defect will be like a big defect, right? You can see a big defect like this. So this is a one wall defect. We have seen somewhere, right? In the beginning, I think. This is a one wall defect, right? So this is a one wall defect. Here you can see, right? So definitely it will stay. If you do a nice suturing, definitely it will stay. Yes. And how to manage horizontal defects. So horizontal defects are like you have to go for a pocket reduction therapy in such condition, and that is a different scenario. We deal with that also in our program. So there's no chance in regenerating the horizontal defects. Cannot be done. There are some advanced techniques, but I don't think that that will be a good option in horizontal defects. And the next question I think is, can lasers be used in regenerative therapy? Not of much use. I am not using lasers for lasers at the most can be used for curettage. It has some effect, but I don't think you can use laser for a defect for regeneration. You can just simply use it with the curates only. You can curate everything out and put graft in that. Prognosis of vertical and horizontal bone loss. Yeah, that's what. Vertical bone loss will have a good prognosis. That too, a narrow angle like here. You can see a narrow angle here, right? So the more the narrower the defect is, the more chance of the regeneration. The more it flattens out, the less the chance of regeneration. So yeah. So the other question is, apart from osteograft, is there any cheaper but efficient bone graft available in Indian market? See, cheaper, definitely available. I'll say a lot of cheaper grafts available. There's a Cybograft. I don't want to take companies' names into that, but just to name a few, there is a cybograph, there is perioglass, there are a lot of graft materials. But after all these years of experience, I find that there is just a difference of 500 or 1000 between these graft materials. But the efficiency of this osteograft is very good. We can get a good bone fill with this, and especially in implant cases, if you use osteograft, it proves wonders. So you can go for a good graft material. I don't find any graft material which is better than osteograft, practically speaking. So LANAP has shown good evidence of bone fill regeneration. Can it be substituted for grafting? Now LANAP is like non. Now, yeah, this is what I wanted to share with you also in the initial stages of presentation. There are two types of regenerative techniques. One is graft associated, the other is non-graft associated. Now LANAP will come under non-graft associated regenerative techniques. It's an entirely different concept. It will never work in a condition like this, where you can find a good defect, good bone loss. LANAP will never work in such a condition. LANAP has a different arena. We are not concentrating on that. That's again a different area. We are not concentrating on. Yes, it has shown good evidence of bone fill. I don't find it has got a good evidence of bone fill. If you need a bone fill, you need to do a grafting procedure. It can never be substituted for grafting again. So which suturing technique will be better in graft placement? So I prefer a sling suture, a pre-suturing with sling suture always. Now, what is sling suture and why it is preferred over interrupted sutures? It will be very complicated if I try to explain it over here. So remember something called as sling suture, which provides a better adaptation of a flap, brings the flap together and keeps a good approximation of the flap. So I prefer sling suture, pre-suturing a sling suture. All this will be covered with our programs. Once you do it on a fixed jaw, you'll understand what is a sling suture. And with a sling suture, I think that the need of placing a pack also is reduced. Most of the times, whenever grafting is done, there will be pack placed over the side. But I think if a good suturing is done and good membrane adaptation is done, the need of pack is reduced. Don't have to give a pack. So definitely sling suture for a good adaptation. Yes. There are vertical matters, horizontal matters also, but they are more complicated. So if you are able to give a good sling suture, I think that should be sufficient rather than your interrupted sutures. That's all. Questions are over.
Yes, sir. I think we'll wind up the session, sir.
Yeah, Shanok, yeah, we'll do that. And if any other queries are there, ask them to put in the box and I'll be happy to answer that later.
Sure, sir. So thank you so much, sir, for sharing your knowledge and expertise when it comes towards regenerative periodontics. And definitely it was a beautiful presentation when it comes towards case discussions as well. So everybody loves clinical oriented webinars as well as workshops. So talking about workshops, so as we mentioned, we are going to have a periodontic skill enhancement program on coming October 9th, 8th and 9th, which is our 12th batch. So this 2 days program will include various flap designs, crown lengthening, frenectomy, curettage, lasers on models as well as going to be on patients as well. So if anybody is interested, please contact the mentioned numbers in the comment section. So once again, sir, thank you. Thank you so much. Thank you all doctors for being here and have a great night.
Thank you, Shanok. Thank you all for patient listening. Thank you.